focuses on the troubling impacts of language barriers in healthcare access. More than 14 million people in the US do not speak English, and more than 25 million people say they speak it, quote, less than very well, unquote, according to US Census data. Language barriers have been associated with limited access to healthcare and poor health outcomes. Non-English speaking patients often receive less preventive care compared to their English speaking counterparts, and they also face greater challenges in accessing healthcare. As the number of non-English speaking patients is projected to increase in the United States, it becomes crucial to develop innovative methods to facilitate communication between clinicians and patients. This week, EMS has collaborated with Stanford's CARE for Health Research, Stanford's Center for Health Research and Education, which is known as CARE, to present the latest data on the healthcare of non-English speaking patients, identify some of the underlying obstacles that hinder their access to care, as well as to explore potential solutions to remove barriers and improve healthcare outcomes for everyone. Our speakers today, and we have a fantastic panel for you. Our speakers today include Dr. Palaniappan, co-founder of Stanford CARE, Dr. Ingrid Hall, Division of Cancer Prevention and Control at the Centers for Disease Control and Prevention, and Dr. Elena V. Rios, President and CEO of the National Hispanic Medical Association. We ask speakers to speak slowly for our interpreters in Spanish, Mandarin, and Korean, and we ask reporters to answer questions in the chat, which we will address following each speaker as time allows. Our speakers are also encouraged to answer questions throughout the conference in the chat after their portion of the briefing has concluded. We will send a video of today's briefing and expanded bios with contact information for each speaker to all participants later today. And so now we begin with Dr. Latha Palaniappan. Dr. Latha, welcome.
Thank you. And thank you, Ms. Sarabji, for inviting the Center for Asian Health Research and Education at Stanford to this convening. And I am delighted to be on a panel with my colleague, Dr. Elena Rios, and looking forward to spending time with Dr. Ingrid Hall. I've read so much about your work. And thank you for bringing us together, Ms. Close, and thank you to Ms. Nina Lee, our community programs manager at the Center for Asian Health Research and Education, who has previously organized a briefing for us with my colleague and co-founder, Dr. Bryant Lin. If we could bring up my first slide and share. So as Ms. Sarabji mentioned, my name is Latha Palaniappan. I'm a professor of medicine at Stanford. And I will be talking to you today about language barriers, as my colleagues will also be discussing. I spend most of my time doing research in diverse populations on Asian, Hispanic, African-American populations in the United States and worldwide. And I teach population health to the Stanford medical students and also residents. And an important social determinant of health is language and language access. So I'm delighted to be diving deep with you today on this. Next slide. So as we all know, but I'll just define for all of us on the call, that language barriers often occur when healthcare providers and patients do not share a native language. And most healthcare providers in the United States speak English, and all of training for medical schools in English in the United States, and all of the testing is in English. And just so the audience knows, there are 3 sets of board exams for physicians, as well as boards for each specialty, and all of this is conducted in English and no other language. And I emphasize this because while some doctors state that they have language proficiency on their websites, for instance, they're often colloquially, conversationally proficient in a language, but not proficient in medical terms. So I just want to also point this out as a sort of a hidden problem, but we have other bigger problems to address, as I'll show you going forward. So patients and families with limited English proficiency, so I'll abbreviate this as LEP throughout the slides, face exacerbated health disparities due to multiple factors, which I'll go over in detail. And there are promising solutions that we have that combine cultural sensitivity, accessibility, and cost effectiveness. And our challenge as a group is to make our populations aware that this is an issue, limited English proficiency, that people with limited English proficiency do face worse healthcare. There are solutions to this by using translation services, and that these translation services are mandated by the government. So to really emphasize to our public that if these are not offered, they should be requested whenever you receive care. Next slide. So as Ms. Sorabji mentioned, America is multilingual, and we are becoming more racially and ethnically diverse. From 1980 to 2019, the number of people in the US who spoke a language other than English at home nearly tripled. And 25.5 million speak English at less than the very well level. And there's about 400 million people in the US. So there's a little bit less than 10%, and 67.2 million people in the US speak a language other than English at home. So this is about 15%. And also I want to emphasize that English proficiency does not necessarily, language proficiency does not necessarily mean medical proficiency. So I would encourage everyone that is listening and everyone that is reading to use a translator whenever possible. Next slide. And if you could just click one more time. So this is the percentage of households with limited English speakers by household language in 2019. And this is from the American Community Survey. And I was surprised to see, if we can click one more time on this slide, there's an animation, thank you. The main languages in people with limited English speakers by household are Chinese, which include Mandarin and Cantonese, Korean, and Vietnamese. So these are the top 3 languages of households that have limited English speakers. And so these are mainly Asian languages, and I want to commend Ethnic Media Services for translating in these languages, Chinese and Korean, and also Spanish. Fourth most common is Russian, Polish, and other Slavic languages grouped, and then Spanish, and then on down the line, as you can see, and a very significant proportion speak another language. Next slide. So patients with language discordant healthcare providers reported receiving less health education, worse interpersonal care, and lower patient satisfaction. And I do have all of the references for this in the notes, and I'm more than willing to share the slides after this as well. And both patients and providers reported less than satisfactory access to adequate interpretation services. And this is a frustration in many healthcare systems due to cost-cutting measures and others. We used to, when I was a resident, have in-person translators that were readily available, maybe within 15 minutes of the visit on the floor. And then we moved to telephone translation, where is not as ideal because you don't have the nonverbal cues. And I would have to sometimes wait for up to 2 hours to get a telephone translator on the line. And now we have also remote services with video, but also this has been limited by limited access to internet services and also limited bandwidth at times. And so people who have limited English proficiency are more likely to report issues with access and coordinating care. For example, you may have a physician tell you to get a colonoscopy, but all of the materials on how to prep for a colonoscopy, the bowel prep, and all of the instructions after the colonoscopy are largely written in English. And the people who pick up the phone don't have access to translation services as much as care providers do. People with limited English proficiency are 4 times more likely to not have health insurance. And the cost per case in people with limited English proficiency is 34% greater compared to people who are English proficient. And this is due to increased ordering of tests, likely because the history is not as attainable with people with limited English proficiency, and this results in more care utilization. Next slide. LEP populations have trouble navigating local healthcare systems, leading to delay in reporting symptoms, not receiving timely care, and higher rates of undiagnosed conditions. So the length of stay, if an interpreter isn't used at admission or discharge at a hospital stay, is increased by 3 days. There's increased 30-day readmissions, for instance, among congestive heart failure. There's more infections, falls, surgical site infections, pressure injuries, delays in surgery, problems with medication management, decreased preventive screening like mammograms, and I know my colleague, Dr. Hall, has done great work on this, and less access to the healthcare system. People with limited English proficiency are 2.4 times more likely to have problems understanding a medical situation, twice as likely to have a bad reaction to medication due to problem understanding instructions. For instance, taking inhalers. If you're not taking an inhaler properly, you're more likely to have an asthma attack. And they're 1.9 times more likely to have an adverse physical event leading to major harm or death. So language barriers are an important issue to address to improve care for people with limited English proficiency. Next slide. So what are the solutions to these problems? One is to translate materials into patients' preferred language. And I'm working with a colleague at Stanford, Dr. Ji-San Hong, who is working with our healthcare system to translate diabetes materials into multiple languages. And often in our electronic healthcare system, Epic is used, and Epic has after visit summaries for patients, but these are all in English. So we're working on those after visit summaries in different languages. Also integrating HIPAA compliant translation tools in tandem with interpretation services to improve healthcare delivery, patient safety, and decrease costs. So as I mentioned, under section 1557 of the ACA, healthcare providers are required by law to provide qualified interpreting services free of charge. And relying on family members and friends as informal interpreters is generally prohibited, except in special circumstances like immediate emergencies. So as soon as possible, you should have a qualified interpreter. And what we're finding is that in-person interpretation combined with telephone or video-based interpretation can be cost-effective and more efficient in delivering care to limited English proficient patients in healthcare systems. It's also important to take into account cultural nuances and ensure the team is on the same page when communicating to patients and preparing treatment plans. For instance, in some cultures, and this changes depending on acculturation and generational status, it's not appropriate to give a diagnosis of cancer, for instance, terminal cancer to a patient. So understanding what the cultural nuances are, and perhaps this should be communicated by the family and with the cooperation of the family, as opposed to an individualistic approach that we more often take in Western systems is warranted. And new therapies via clinical research are not accessible due to lack of readily available translation services for trials. So I work in the clinical trial space, and what we do to try to bring new therapies to people who are limited English proficient are we employ bilingual staff. We leverage multimedia methods such as translating consent forms and implementing trainings to help address system and individual barriers to research so that everyone can benefit from new drugs and devices and clinical trials. And we're also now at Stanford experimenting with ChatGPT and other resources to help bring services to our patients with limited English proficiency. So with that, I will close and thank you, and looking forward to hearing from my colleagues on the panel.
Thank you. There are a number of questions for you before we move on to Dr. Hall. Mira Kaimal, the managing editor of India Currents, asked this question. Do you have data on the elderly population? How are the limited English proficiency elderly impacted?
So there have not been studies that I am aware of that have specifically separated out the impacts of limited English proficiency in the elderly versus younger populations. The ill effects of not having readily available translation services is the effect size is the same for elderly populations versus younger populations. So it's a problem across the lifespan, I will say. And there has not been an interactive effect that has been detected, but I'll maybe turn it over to Dr. Hall, because I know she recently did a study in MEPS, and maybe you're aware of any age interactions, or Dr. Rios.
Yeah, Dr. Rios and Dr. Hall, could you weigh in on this question before we move on to the next question from Henrietta Burrows?
So I was also going to say, I haven't seen any studies that have divvied things out by age, but I think it's possible to do if people know that that information is needed. So maybe a study will be, an analysis will be coming out in the next year or so.
Yeah, I'm only familiar with the research done by the Office of Minority Health at HHS on cultural competence. And there was a huge study done. It was actually supported by OMH. Again, it was like, over 15 years ago on the geriatric population. So I know that there has been work done on the geriatric population, maybe in geriatric journals or the associations related to geriatrics.
Thank you. As Mira points out, this is an especially vulnerable population. We move on to a question from Henrietta Burrows. Henrietta, welcome.
Thanks, Sunita. Could you tell us why a patient who is not English proficient suffers from more pressure sores? Does this represent a lack of a bias and a lack of care on the part of the caregivers?
That's an excellent question, and this I think boils down to all of the care team not having access to interpreter services. So the physician might come in and have access to interpreter services, but every time the nurse comes in to take vital signs, for instance, or to turn the patient, or to change the sheets, or to bathe the patient, the nurse in those interactions, or the MA, medical assistant, is in situations where there's English proficiency, is conveying information, right, to the patient. That's all part of a care continuum. And that care continuum is interrupted for a patient with limited English proficiency. So when, for instance, they're getting bathed, the nurse is not able to communicate to them. It's good if you move your legs or turn over, or even though I'm required to turn you over every 2 hours, you can also do this to prevent the pressure sores. So excellent question, and more research specifically needs to be done on impacts in nursing care.
Absolutely. A couple of questions have come in via text. How effective are translation services versus patients directly being able to speak to their physicians? As you mentioned, Dr. Latha, a lot of times these are phone services, which suggests an immediate barrier between patient and doctor. Can we break through those physical barriers?
I'm going to go back and draw on my time in Doctors Without Borders. I was a volunteer in East Timor in 1999. And in the emergency situation, I worked through translators who were college students, and their education was interrupted by the conflict in East Timor. And they were 18 years old, and they were translating for me, and patients were telling them that they had been raped or tortured, and a not trained translator is not appropriate to provide medical care, right? Because they're trying to process that information and, translate it to me without medical knowledge. And then I'm, trying to help the translator process this information and provide care for the patient. So that's an example of where a not well-trained translator can really detract and may also be harmful to the translator. I did get a chance to go back on my 25th anniversary, and I met the translators, and they've all gone into government, not medicine, I think, as a result of that early experience. But a good translator can help and I really thank all the translators that I've worked with in my life, and also those of you who may be in the audience. But a good translator can really add to the care, because they can really assure that the patient understands everything, and and also slow down the doctor enough that we're spending enough time to make sure that the full communication is occurring. There's many studies that show that patients only remember 20% of what a doctor tells them in a room. And so it's always a good idea to bring someone else with you to a medical visit, because more ears will hear and retain more. But a translator can really help with that retention and understanding in a medical setting.
Thank you. And a final question for you. Will cost-cutting health providers turn to artificial intelligence as their solution to language access? And is this already happening?
I think it will be an augmentation or an adjunct to translation services, and this is well needed. And I will say that at Stanford and other healthcare institutions, before these artificial intelligence methods are utilized, they're well studied. For instance, my group studied ChatGPT for diabetes, and we found that it was 75% accurate. So obviously can't replace a care provider, but can definitely be a good adjunct. So these all have to be well vetted before they're deployed in healthcare systems.
Thank you. One final question from Seema Gupta. Sorry, the questions keep coming through, so I'm hoping you can just answer. Seema, please ask your question.
So this, I'm sorry, this is Amar. Seema is not here right now.
Hi,
But
Amar.
I would just like to ask, do you see technology or AI to be a friend for both the patient and the doctors? Because it could be a simple solution to a very big problem of language barrier.
Absolutely. This would be a very useful adjunct, and studies are being done for that now.
Thank you for joining us. Please stay on. We have a final round of questions at the end of the briefing for all speakers. We move on to Dr. Ingrid Hall from the CDC, who will discuss the impact of low English proficiency on health screenings and perhaps early interventions. Welcome, Dr. Hall.
Do you have my most recent slides I just sent you?
In
your email?
I don't think
It's
so.
okay. It's okay if you don't.
Do you need Jessica to run your slides for you?
Yes, please.
Okay, Jessica, do you have Dr. Hall's slides?
Did you send them to me?
No, I can run them from here.
Okay, I think that might be best, Dr. Hall.
Okay. Can you guys see?
Not yet.
I think I need to share.
So the button is at the bottom of the screen. It should say share screen, or you might have to click more and then it'll say share screen. There we go.
There you go.
All righty then. Okay, well, I'm Ingrid Hall from CDC, and today I wanted to present an overview of a recent study we published last year in preventive medicine that can be accessed at the link shown there. In this analysis, we wanted to explore a little study group, Hispanics that don't speak English well. And as we've learned from Dr. Palaniappan, I hope I'm saying that right, that this group is termed having limited English proficiency, or LEP. How do I get this to go to the next? There we go. All right, so when you read the literature, you see that Hispanic adults are less likely to receive timely cancer screenings, with even lower screening prevalence reported amongst the recent immigrants, those who are less acculturated, or those showing less adaptation to American life. The analysis that I'm going to talk about explores the association between Hispanic ethnicity and not speaking English well and access to healthcare services, particularly on the receipt of cancer screening. So the most important, most commonly used definition of people with limited English proficiency is those people who speak less than very well. So that group does contain some people who speak well. Our analysis describes health outcomes for the population with limited comfort speaking English. So people who speak English not well or not at all, right? So this is a smaller group that has poorer English speaking skills than those with LEP, who are the ones that are usually most studied. So in order to do this, we pulled together 3 years of data from 2013 to 2016 of the Medical Expenditure Panel Survey. It's a nationally representative survey that collects data on healthcare use, expenditures, source of payments, insurance coverage, and quality of care for the US population. So on this slide, and I'm sorry for all the numbers, I'm an epidemiologist, and this is what we this is what we do. But on this slide, we show some measures of regular access to healthcare services for 3 different groups. And if we look on the rightmost group, the NHW in Black, everything we do today is going to be compared to responses for non-Hispanic whites. So we can, and all these numbers are percentages, so we can see that 84% of non-Hispanic whites reported that they had a usual source of care. They have a regular doctor, right? The middle column is Hispanics who are comfortable speaking English. So when we asked them if they had a usual source of care, only 78% of Hispanics who speak English well say that they have a usual source of care, and the red indicates a statistically significant difference from the responses for non-Hispanic whites. If we continue to move to the left, we have the column for Hispanics with limited comfort speaking English. These are the people who don't speak English very well, and only 69% of them report having a usual source of care. So you can see a downward gradient from non-Hispanic whites at 84% who speak English well, to 78% for Hispanics who are comfortable with English and speak English well, down to 69% for those Hispanics who report that they have trouble with English. If we skip down to the second set of numbers under the preventive services, these are measures that people would just generally get at a routine checkup. Blood pressure in the last 2 years, cholesterol in the last 2 years, an annual flu shot, a physical, or go to the dentist every year. And so what we see in the LCE column, all those numbers are red and are lower than the numbers in the center column. So that means that Hispanics who don't speak English well report receiving fewer of these services at a lower percentage than Hispanics who say that they speak English well. The red column in the middle for Hispanics who speak English well, even those red numbers are still less than what the non-Hispanic whites report as their percentage for receipt of blood pressure, flu shot, or going to the dentist. The bottom panel of measures is healthcare utilization. So we wanted to see how many people say that, no, I don't walk into the doctor. No, I haven't had any emergency room visits. I have not had any inpatient hospital discharges, no dentist visits, and no prescriptions. And we can see here that the numbers for the limited comfort speaking English column, those percentages are higher because these are people saying, no, I have not made use of any of these healthcare services. So more people who don't speak English well have not made use than the middle column, the Hispanics who speak English well. And the red numbers for those who speak English well are still higher, have not made use, than the percentages reported by non-Hispanic whites. So we can start to kind of see the impact of familiarity with English and how that impacts people's access to preventive services and use of healthcare services. When we look at this for cancer screening, this is just a different way of showing you what I've already showed you before. Cancer screening for breast, cervical, and colorectal cancer, we're going to start with the dark blue column that represents the percentage of non-Hispanic whites who said that they got a mammogram in the last 2 years. So that's 62%. We can see that this red column, which is Hispanics who have comfort with English, reported an increase over that at 71%. That was statistically significant. That's what the asterisk is for. And then the light blue column is Hispanics who have limited comfort with English also received mammograms at a higher rate than non-Hispanic whites. We see the same pattern for receipt of Pap tests, which tests for cervical cancer screening, where Hispanics, regardless of their ability to speak English or not, right, well or not, received more mammograms than non-Hispanic whites. And when we look at colorectal cancer screening tests, which included colonoscopy, sigmoidoscopy, FOBT, and FIT, across the group, people were getting those tests at a similar rate. So we might be surprised at the finding that Hispanics receive more breast and cervical cancer screening than non-Hispanic whites when their use of other types of preventive care, blood pressure checks, flu shots, going to the dentist was actually lower. So it kind of, seems like an oxymoron, or like doesn't quite make sense. And what I'm thinking is that the explanation for that speaks to the impact of CDC's National Breast and Cervical Cancer Early Detection Program that screens low-income and uninsured women across the country for free through the health departments. So this slide shows the race of new enrollees over a 9-year period of time. Hispanics represent the blue line, and you can see as time goes on, nearly 50% by 2019 of all CDC screenings for breast and cervical cancer are going to Hispanic women. And so I think that's what's making some of the results that I'm seeing in this analysis. So many people don't know that CDC funds state health departments to screen low-income, uninsured, and underinsured women of any race to get free mammograms and pap smears across the country, territories, islands, all of that. And so you can find out more information about CDC's breast and cervical cancer screening program, as well as our colorectal cancer program at the highlighted link at cdc.gov/cancer. So there's a couple of limitations to this study. Our data were self-reported, and so people may have felt like they needed to say that they understood English or more comfortable speaking English than they really were. And if that's the case, our numbers would change somewhat. One of the other limitations is that our study uses LCE, which is a measure that most studies don't. Most studies look at LEP. So we're looking at different populations. And so we can't really directly compare these results to what other people have done because we're looking at slightly different populations. However, we were interested in trying to represent the healthcare experiences of people who had the poorest language skills. So in conclusion, compared to non-Hispanic white adults, Hispanic adults as a group have poorer access and use of healthcare services, including some preventive services, although mammography and pap test screening were higher. Hispanics with limited comfort speaking English seem to fare worse than their counterparts who express comfort speaking English. So what can we do about it? Some of the things that can be done are to provide more appropriate language assistance at the point of care, to tailor care to be culturally and linguistically appropriate for the clients that you're serving, to strive to improve health literacy. So people need to understand why they're having to have the care that they're getting, what the trade-offs are, what the importance is to them of following screening recommendations is. And lastly, we can address barriers to care such as discrimination and bias. So language assistance may reduce health disparities for Hispanics with limited comfort speaking English and their families, but we want to eliminate disparities for all Hispanics, even those who speak English well, and that might require a multi-pronged approach that includes addressing disparities in education and insurance coverage and other social determinants of health. So I thank you for your time and attention, and I'm happy to address any questions.
Well, there are a number of questions for you, Dr. Hall, as anticipated. But I would like to start out with a comment that Pedro, and Pedro, I'm going to butcher your last name, so forgive me. But could you please repeat the comment that you posted in the chat?
Well, yes, I did 2 comments, and the first one was that I was really happy to see all the numbers because I'm a stats nerd, but I think the most important one that was being referred is that it's really cool to see so many people that are researching these topics and that are so passionate about trying to help others. It makes me really hopeful for humanity. But the number stuff was really cool too.
Great. Well, what I
So-
wanted to say before we get started with the questions is it would be really easy for me to redo this analysis and break it out by older and younger LCE populations, which was the question that came up with the last speaker. So I may go back and do that and see if there's anything worth reporting on.
And we would love to have you back to share that data with us.
Okay.
We have questions from Henrietta Burrows, Chutse Chu, and Linda Gaindo. Let's start with Lilia Gaindo. Lilia, could you ask your question, please?
You know, I was just wondering if the statistics show that people who doesn't speak good English receive more services, because when you analyze the statistics about the kind of illness that Hispanics have, colon cancer is high index, diabetes, hypertension. So if I am a doctor and I don't understand exactly what the person is telling me, so I would order just to be sure that they don't have that kind of problems. Could be possible that situation. Thank you. I hope that you understood me.
I think the question was, could people who don't speak English very well be receiving more services? Is that what you said?
Yeah, you were saying that the statistics show that they receive higher services than the white people or something like that, no? Did I understood correctly?
Well, so actually they don't. They just happen to receive more cancer screening, breast and cervical cancer screening is what I was saying.
Okay,
but for other preventive services, and I only looked at blood pressure, cholesterol, flu check, and go to the doctor. No, the receipt of those services is way down comparatively.
Chutse Chu has the next question. Chutse?
He asked that you ask his question for him.
Okay. What has government done to address issues found by this research, both at the federal level and at state and city levels? That's a broad question, but.
It is. So I can only speak for CDC. So CDC's part is we get money from Congress to funnel into breast and cervical cancer screenings that we give to all the state health departments across the country. So a lot of those health departments, especially in states that have a high Hispanic population, put a lot of their outreach into targeting Hispanic women, low-income Hispanic women, and particularly Spanish-speaking women. So we kind of feel like that's our niche. You know, it takes a village, right? But that's our niche and that's what we do. And we've managed to increase the numbers of Hispanic women getting screened through the program to nearly 50%.
Interesting. Henrietta Burrows asked a question that also came to my mind. Henrietta, please ask your question.
Thanks. The emphasis here has been put on English proficiency as a determining factor, but I'm wondering what relationship does income play? Because I think the statistics show that those who have more money seek more health care, and those who are English proficient, let's say Latinos who do speak English, have a higher income, more access to jobs. So what's the biggest determining factor? Is it English proficiency or is it income?
Okay, so I took this slide out because I was trying to be conscious of the time, but this is just kind of the sample characteristics, and we can look down here where we've characterized income as less than 100% of the federal poverty level, or between 100 and 200% of the federal poverty level. And you can see that the percentages there are highest across the three groups for those who don't speak English very well. So the cancer screening numbers that I presented were adjusted for income. So they were adjusted for age, education, income and insurance coverage. Now, the thing is that if you get screened through CDC's B&C program, we particularly screen people who don't have any income. We screen people who don't have any insurance. So my analysis controlled for those things, but we still see that, at least in this data set, that Hispanics who don't speak English well still receive a fair amount of breast and cervical cancer screening despite having a lesser income. Did that
Thank
make
you.
sense? I think that
Question,
makes sense.
question from Arceli Martinez. Arceli,
Hello, Sunita.
hello.
I
Welcome.
wonder, thank you. I was wondering if there is a program or any plan to encourage physicians to learn Spanish or other languages as Mandarin. So in that way they can help more to the patients, because if you notice that they make an effort to speak your language, you feel more confident. Have you heard any plans about this? Thank you.
I have not. I'm not a clinician and I don't see patients and I don't really know what goes on in doctors' offices. So I'll defer that question to the other panelists who may see patients and have a better idea of what goes on in clinics and doctors' offices.
And Dr. Hall, one final question before we move on to Dr. Rios. And reporters, we are going to run a little bit late, so please do stay on. But Dr. Hall, has the CDC partnered with community-based clinics to provide these basic screenings and referrals?
Big question. So we try to do that. I think the onus is more on the state health departments. So our money goes from Congress that goes directly to the state, and then we encourage our state partners to then partner with community-based organizations that are going to reach the populations that we want to reach. I can't really speak today about the efficiency of how well that's working, but I know that's how it's supposed to work.
Well, thank you, Dr. Hall. Please stay on for the final round of questions. And we move on to Dr. Elena Rios. Dr. Rios, welcome.
Yeah, thank you. So I'm in Washington, D.C. I'm president of the National Hispanic Medical Association. And, you know, we started the organization just because there was so many issues related to in the healthcare arena related to our communities. And there was no medical association to bounce off ideas, to mentor and to develop leadership so that we could get into positions to help change things within the healthcare system. And that's exactly what we've done. And just to comment on a few things that have been stated, you know, there's lots of barriers when you think about language in healthcare. You have to think about the system, the systemic barriers. And we all know there's discrimination. When we go to medical school and residency, we learn about diseases. We don't even think about the patients. It's well, here comes the diabetic, or here comes the person with cancer. And so language in our own profession is part of the problem. You know, and the other issue really is racism and discrimination that our patients talk about of the providers, since there's so few Hispanic physicians or Black physicians, or you know, the physicians, Native American physicians, some Asian physicians, and so you don't get the racial concordance between doctors and patients, and so sometimes that's a problem. And then there's also the problem of just relationships not being able to be done in a more personal way. You know, when people get sick, especially elderly, they revert back to their language of comfort. Latinos in this country that have come from other countries, my grandparents, for example, were immigrants from Mexico. We have a lot of Asian and I'm from California, I'm from Los Angeles. So I know all the Asians that came over from the Vietnam War. When I was a resident, we had to take care of them, and they were all, you know, refugees. And we get refugees now across the southern border, especially from all different kinds of countries. And we even have more languages now from indigenous people, from the areas in Latin America where there's still indigenous speaking natives. And so there's all kinds of barriers. But I think what's important is think about the individual and what can we do for the individuals to feel like they are respected. We need to talk about respect and have stigma and don't want to talk to their providers because they think they don't understand them. Or there's the lack of, and we've heard over and over again from the other speakers, how important it is that the people that have limited English proficiency get dissatisfied with care and don't come back. And then they have the worst outcomes. So we're talking of disparities in this country where the majority of people in this country are from people of color that have connections to limited English proficient patients within our communities. So it's a really big deal. There was a study from Health Affairs that just got released talking about the fact that there was lower funding for seen by the LEP patients, less healthcare spending. But the issue becomes a reality when you realize from the legal perspective or from the policy perspective that only 15 states actually have Medicaid, their own state Medicaid or children's health insurance programs that reimburse for language services. So we need to change the system. We need to reimburse language services for providers, for hospitals, for clinics, for doctors' offices, to actually get paid for language services. And now that we have more telemedicine, because of COVID-19 and the rise of telemedicine and website platforms and all of the social media information that patients look at now, that wasn't there, 10, 15 years ago, we need to think about language services there also, and translation services. And that is a cost within the healthcare system. I guess the other thing, I'm just going to focus just a couple things. One is on the congressional laws that have been done, that have been introduced. And I wrote a few down only because it's important to know. Judy Chu, Congresswoman Judy Chu is from Monterey Park, California, and she's introduced in the House Ways and Means Committee the Health Professions Opportunity Grant Program to increase resources for training and also increase resources for childcare for people within, I'm going to say, well, it's a special grant program that would go to nonprofits. Okay. The other Asian Congresswoman, Grace Meng from New York, has introduced the mental health workforce and language access for health centers, for community health centers to be able to have better mental health services. Her laws are looking at how you can increase support for training of the healthcare workforce in language access. And then Jimmy Gomez, who's a Hispanic congressman from Los Angeles, he has the Language Access for Medicare Beneficiaries Act, which is important because these are people over 65 and to have language services for this population. So that's just an example of what is going on at the federal level. At the state level, I'm not familiar with all the different states, but I can tell you that in California, there has been major moves for language. One of them is for high school students in the public schools in California to have on their diploma a special badge, badge of honor, whatever, a good housekeeping seal of approval, that you can talk another language, that you are bilingual. Now, the testing and the requirements I'm not familiar with, but I do know that the congressman who's a doctor, an emergency room doctor from Fresno, California, Dr. Arambula, he's an assemblyman. I met with him earlier this year. I meet with different assembly people and senators from different states, especially the Hispanic states. And when we do a lot of advocacy for health, he would like to develop the same concept for medical students or for nursing students, to have testing and requirements that are standardized for languages such as Spanish. Or, I mean, in California, 40% of the population is Hispanic, so there's quite a few, quite a need, but also for the the Asian languages that were also meant, Chinese, etc. The other thing that I just thought of for recommendations that have been tried. There are companies that have licensed to medical schools for curriculum for medical students to learn Spanish. Canopy is one of them, and it's a company out of New York. There's also been quite a movement within medical education over the years for students to have brown bag lunches and elective sharing of their knowledge. Spanish-speaking students, for example, teaching others in medical school about Spanish. But again, as was mentioned, it's not medical terminology that most Spanish speakers come from families that have Spanish in the home, but they don't have fathers or mothers that are doctors and nurses. So we have to be careful about that. And then I also think that testing is important, and Kaiser Permanente is an example of a system who has required testing for certain levels of proficiency of language. So for the Latinos doctors in Kaiser who say they are Spanish speaking, they have to go through training and pass exams to be called on, as a translator. But I think overall, the other issue is, do we bring in more doctors from other countries that talk Spanish? And that's something that we have seen is hard because there's a quota system, and there's more foreign doctors that come from India and China than Latin America in this country. And that's a reflection of the policies of the ECFMG and Congress. And I don't know where you change that, but we definitely need to see the need for language services could be helped by having more doctors or nurses, for example, from those countries that speak the languages that are needed here. And then the other thing I'll say is that there's definitely a need for reimbursement at all levels, but reimbursement especially in the poor communities that don't have top jobs or don't have higher incomes and don't have insurance, so that more community. And it's hard to think about this, but most people don't go to the doctor because they can't pay for it and they don't have insurance. So we continually need more prevention. And as was mentioned by CDC, our organization, the National Hispanic Medical Association, does get grants for social community-based efforts with working with partners in communities that are not medical, for example, not clinics, but community-based groups. We do social media, and we also do just education of the community in general through health fairs and those types of things. And I think that it's important to realize that so many people do need educational information in order to feel like that they are welcome to join the healthcare system. But we do need healthcare people that talk to them, whether it's community health workers, more community health workers, more volunteers who are Spanish speaking or speaking the languages of the patients. So I'll stop there. I think this has been a great opportunity to share ideas, and I'll just stop there.
Dr. Rios, a couple of questions. First of all, we rely a lot on children to provide translation services for their parents. How does that affect, first of all, patients' privacy and also their ability to directly engage with their physicians?
Yeah, I think we heard that earlier too, that it's really not good for the patients. It's disrespectful, really, to have a mother or father have their children have to translate. But at some point, perhaps it's necessary for some basic information. But when it comes to the personal information, that's not good. And I think that again, it's the systemic changes that need to happen in our institutions, hospitals and clinics, and they should have access to some type of service, interpreter, translator service.
Mhm. And, I think to one of the most important things coming out of this briefing is that clearly the need to create a pipeline of culturally sensitive healthcare providers. And yet, at this point, less than 6% of our healthcare force are people of color. What would you say about that need to create that pipeline and the barriers to creating that pipeline?
Well, the biggest barrier right now is the US Supreme Court's decision not to have race-based admissions into any higher education, which is community colleges, universities. And you need to have at least 3 years of requirements to get into medical school or dental school or pharmacy school. And I think that we have to do what we can. We have a NHMA College Health Scholars Program. We mentor. We have mentors from medical students to mentor pre-med students, and public health students to mentor pre-public health students. And I know the Hispanic nurses, Hispanic dentists, other groups all do the same thing. We're very interested in having more of our professionals who have struggled through their educational career, to help and give back. We also give scholarships to those students who are very interested and committed to helping our underserved communities. They don't have to be Hispanic, but it is a scholarship for those students who made it into professional schools, who need that extra funding because we all come from families that are middle class or lower middle class, and we know how hard it is to give up working and going to school for so many years. Anyway, I think the other thing is the parents do not realize, because many of the parents from our communities that are not professional parents, that come from lower, from Latin American countries where they only go to school till middle school and then get married. There's a big tradition in our communities of the values of working, the values of getting married, having a family, and they never thought that their family, their children could go to medical school or dental school and in 10 years, right, waiting 10 years, could have a salary that's 3 times the average in our country. And it might not be that much to people, but it's a lot to the families. And eventually, most of the students who go to medical school that come from lower income families end up helping their families anyway. So it's just a matter of being able to help them even more. So the pipeline approach is important. The pathways, the mentoring especially, we have found really works. Students can be very intelligent but be the first generation student that goes to college and don't know the first thing of how to study their science courses, especially organic chemistry that needs to be passed to get into medical school or dental school or pharmacy school. So we have a long way to go, but those programs do exist, and I know the many institutions, all the universities and colleges that have medical schools, for example, get a lot of money to recruit and to help students prepare for the exams and interviews and all the steps needed to become a doctor or a dentist or a nurse. So we need to do more of that. We need our state governments. I know in California passed a beautiful law. I can't believe it, but they increased the taxes on the insurance companies in California to provide more residency slots in California, and also to give more funding for the clinics in California and more training for the pipeline programs. And that just happened with this, with whoever the leaders are of the health committees of the Senate and the Assembly in California, along with Governor Newsom. They decided that healthcare training and education was so needed that they did that.
Absolutely. We have time, or I'm sorry, we should have had time for one final question, but I see we're out of time. So thank you to all our speakers today, and thank you for reporters. We'll see you next Friday.